BrieSalagarasWeek2, and today I'm going to be talking to you about hypertension. The case study is Tom. He is 56 years old, has an office job with long working hours, does no physical activity, smokes a pack a day of cigarettes, and his diet consists mostly of takeaway food. He drinks 2 to 3 alcoholic beverages a day, and his blood pressure is 147/88. His BMI is 33 kilograms per metre squared. He is obese. So what is Tom's blood pressure classification? Tom has systolic hypertension, which is, according to the National Heart, Lung and Blood Institute, a systolic pressure of greater than or equal to 140 mmHg and a diastolic pressure of less than 90 mmHg. Essential hypertension is high blood pressure without the presence of any other diseases. It occurs from non-modifiable and modifiable risk factors, the non-modifiable being family history of high blood pressure, increasing age, so greater than age 50, because that's when systolic increases and diastolic starts to decrease, male, gender, race, African Americans, and insulin resistance and metabolic abnormalities. These can be genetic or developed as a result of inclusion of the modifiable risk factors in their daily lifestyle. The modifiable risk factors include high salt intake, so although evidence is strong for decreased salt intake and decreased blood pressure, the mechanisms aren't entirely understood yet. It's thought to be related to salt causing increased blood volume or an increased sensitivity of the cardiovascular or renal mechanisms or the sympathetic nervous system roles. Obesity, so weight reductions of as little as 4.5 kilograms can produce a decrease in blood pressure in overweight people. Dietary intake of potassium, calcium, magnesium, smoking, intake of saturated fat and cholesterol, and physical activity levels. So what is his blood pressure target goal? Well, normal blood pressure. So as the National Heart, Lung and Blood Institute state, systolic less than or equal to 120 mmHg over a diastolic of less than or equal to 80 mmHg. Tom's risk factors, well, he's male, over the age of 50, has a high takeaway consumption, high intake of salt, saturated fat, cholesterol, is obese, physically inactive, a smoker, and by the sounds of things, he could possibly have metabolic syndrome. My recommendation would be that Tom needs to make some lifestyle changes in regards to his modifiable risk factors and aim for a goal normal blood pressure of 120/80. So next I'll explain the significance of sustained elevated systolic blood pressure in terms of the cardiovascular risk, even in the absence of diastolic hypertension. So with increased systolic pressure, increased complications occur within the heart. High blood pressure thickens the blood vessel walls and increases the risk of atherosclerosis occurring, thus making the vessel walls more rigid and more stiff and narrowing the lumen of the vessels. In addition, stretching of the rigid arteries and veins during elevated pulse pressure causes elastic tissue damage, which can lead to aneurysms and further formation of atherosclerosis and thrombosis. Increased cardiovascular risk occurs with raised systolic pressure and inconsistent rise in pulse pressure. The larger the pressure difference gets between systolic and diastolic, the more atherosclerotic stiffening of the aorta and blood vessels occurs, thus causing a smaller, stiffer reservoir where the systolic inflow into the chamber rises pressure and diastolic emptying decreases pressure. In addition, these elevated pressures increase the heart's workload. So this increase during systole often leads to the heart's wall thickening and the left ventricular hypertrophy. As levels of atherosclerosis increase, there is also increased myocardial and body oxygen demands placed on the heart to work harder, and after a period of time, the left heart failure occurs. All of these confounding factors can eventually lead to alterations in heart rate, which also poses risks for atrial fibrillation, premature contractions, or ventricular tachycardia. Because blood flow doesn't flow as quickly with these irregularities, clotting occurs more frequently, posing increased dangers of clots and stroke occurrence. So 2 secondary conditions that Tom is at risk of developing due to target organ damage if he is unable to reduce his blood pressure. I'll describe the pathophysiology of it. Hypertensive chronic kidney disease. Firstly, it's important to note that although current levels would be placing stress on the kidneys, we would expect Tom's blood pressure to increase, particularly systolic reading, for him to be at an increased risk of this occurring. So hypertension causes increases in the systemic pressure and damages the renal arterioles and small arteries, causing atherosclerosis. Usually both kidneys are involved and they become smaller than normal. The afferent atrials have high pressures and they try to compensate for these by constricting the smooth muscles and decreasing the flow and pressure into the atrials. As the pressure is high for a long period of time, barrier trauma occurs to the smooth muscle cells and the endothelial cells. Smooth muscle cells then extrude cytokines, fibrocollagen, and lipids below the endothelial cells, which is how the lumen of the vessel starts to narrow. Thickening and hyaline atherosclerosis of vessel walls cause narrowing, decreased ability to constrict, and perfusion diminishes. Ischemia, tubular atherosclerosis, changes in glomerular structure and function, and later necrosis can eventually occur due to the easy elevation. Another condition is hypertensive heart failure. Hypertension causes a ventricular overload and ventricular hypertrophy. As amounts of pressure increase in the left ventricle, either due to increased resistance of the aortic valve or arteries, or larger volumes of blood being moved, more muscle is generated to increase the force and ability to push this blood out. This is known as left ventricular hypertrophy. Left ventricular hypertrophy uses more oxygen and energy to contract. However, blood is not able to get to all the areas of the ventricle at once as it becomes larger, and so myocardial infarction can occur in areas where oxygenated blood doesn't reach. This is usually exacerbated by the left ventricular hypertrophy, where the wall thickens and the capacity of the left ventricular chamber becomes smaller. The Framingham study showed that systemic levels above 140 mmHg, if prolonged, will cause left ventricular hypertrophy. The earliest stages of these are seen by an increase in the transverse diameter of myocytes, often accompanied by interstitial fibrosis. Factors such as growth hormone, thyroxine, volume and pressure loading are all responsible for myocyte proliferation. Similarly, angiotensin II, endothelial 1, and aldosterone play a role in fibroblast proliferation. So the two modifiable risk factors that I would prioritise to commence in Tom's intervention would be exercise and diet. Now, non-pharmacological management such as exercise prescription has been recommended as a technique for lowering blood pressure since 1982. One study examined the effects of exercise on arterial stiffness on 53 newly diagnosed adults with essential hypertension. They found that when using applanation tonometry, that pulse wave velocity and augmentation index were inversely associated with physical activity. Sedentary lifestyles lead to obesity, which also leads to an increased heart rate and blood volume. It also leads to an increase in systolic and diastolic pressure. Therefore, exercise and physical activity increase energy expended, decreasing body weight, heart rate, blood volume, and resulting in a drop in mean arterial pressure. Increased exercise is also shown to encourage the formation of new blood vessels from pre-existing vessels and normalizes atrial skeletal muscle resistance. In addition, it enhances the vasodilation via endothelial release of nitric oxide, prostacyclin, and endothelium derivative hyperpolarizing factor. Increased length and lumen diameter basically slow the blood flow to the heart with lower blood volume, meaning that less peripheral resistance and arterial pressure for the left ventricles, thus allowing it to normalize in size. Decreases in noradrenaline and angiotensin II mean that less sodium, water, and potassium are reabsorbed into the bloodstream, and hence blood volume decreases. Tom's diet is another area that would need to be looked at as a modifiable factor to help lower his blood pressure. By looking at his diet, we would be targeting obesity, which basically weight loss lowers obesity and blood pressure levels, and we'd also be lowering his waist to hip ratio, which is linked to high blood pressure as well. We would need to look at the sodium in his diet, so by decreasing sodium, we decrease hypertension, we decrease the constriction of the lumen, we also decrease the cardiovascular and renal mechanisms to the sympathetic nervous system, we decrease blood volume, and this lessens the effect of the renin-angiotensin-aldosterone system. The INTERSOLT study found that as sodium decreased in populations, basically so did the level of hypertension. Potassium, magnesium, and calcium, well, high levels of these are associated with low levels of blood pressure, as is found in a lot of vegetarian diets. However, when tested, individually these nutrients were often too small to detect or had an interaction with other nutrients and hence were thought to be possibly a cumulative effect of them all in the diet, but more study is needed in this area. The DASH diet, Basically, it's called the Dietary Approaches to Stop Hypertension trial. It was a multi-centered randomized feeding study that tested the effects of dietary patterns on blood pressure. It consisted of basically low-fat, low-salt, low-sugary drinks and sweets, and incorporated fruits, veggies, low-fat dairy, whole grains, chicken, fish, and nuts, and they found that it lowered blood pressure. So, whilst it's important to note that Porther Mathvin's 2009 textbook does state that smoking and saturated fat intake do not directly affect blood pressure, they do increase the risk of cardiovascular disease and atherosclerosis, and therefore should be avoided because they can also lead to... Tom's GP stated that if he was unable to reduce his blood pressure via lifestyle modification, then he would need to take a pharmacological approach. I'll discuss these options now. Thiazide diuretics, these enter the lumen of the renal tubule by the process of glomerular filtration and bind to the chloride site of the electroneutral sodium chloride transporter and inhibit reabsorption of sodium and chloride. Thereby, higher concentrations of sodium, chloride and water stain the lumen of the renal tubule, and as these concentrations increase, the sodium-potassium exchange mechanism is stimulated, causing secretion of potassium and more sodium being absorbed. This causes increased outputs and decreases the level of sodium, chloride and potassium in the tubule, leading to a reduced end-diastolic volume, low cardiac output and decreased mean arterial pressure. As a result, often low sodium levels occur and reduced renal blood perfusion. Activating the renin-angiotensin system causes negative feedback. Even with this negative feedback, the reduction in mean arterial pressure remains lowered. This is often negated by using ACE inhibitors or angiotensin-1 receptors in conjunction. Thiazides also open ATP-sensitive potassium channels in the arteriolar smooth muscle cells, causing calcium channels opening to be decreased in size and hence less calcium can enter. Thus, arteries dilate and less peripheral resistance occurs. Side effects: gout, hyperkalemia, hypoglycemia and impotence. Calcium channel blockers. These medications rely on the inhibition of calcium into the vascular smooth muscle cells, either extracellularly or intracellularly. The dihydropyridines are located on the extracellular surface and they blockade the L-type voltage-sensitive calcium channels and hence are not dependent on the frequencies at which these channels open. These bind best when there is a low resting membrane potential of the cell, which usually means the L-type channels of the vascular smooth muscle, as the cardiac muscle potential is much higher. Thus, they have little effect on heart rate, but if caused blood pressure to drop too quickly can result in tachycardia. The phenylalkylamines and the benzodiazepines each have intracellular binding sites, so they find the frequency of the L-type calcium channel opening. Because cardiac tissues open more frequently, these drugs are more useful at decreasing blood pressure through dilating the atrials and decreasing peripheral resistance from within the cells. But unlike the dihydropyridines, these often cause no change in heart rate or bradycardia due to their most common site of action within the cardiac tissue. In summary, the mechanism by which these drugs work is the dilation of atrials via decreased calcium within the cell and hence decreased peripheral resistance and lowering of blood pressure. Side effects can include flushing of the skin, headaches, dizziness, gravitation or edema, constipation, bradycardia, heart block, and precipitation of cardiac failure. Angiotensin-converting enzyme inhibitors decrease angiotensin II production. ACE catalyzes the conversion of angiotensin-1 to angiotensin-2, which is a vasoconstrictor, and promotes the release of noradrenaline, which stimulates aldosterone secretion whilst inactivating bradykinin as a vasodilator. However, these are contraindicated with thiazides and beta-adrenal receptors. Side effects include dry cough, angioedema, prolonged hypovolemia, and contraindicated in patients with renal stenosis. Angiotensin II antagonists compete with the angiotensin II for occupancy of its receptor cells, cause arterial dilation, decrease peripheral resistance, and decrease mean arterial blood pressure. Side effects are hypovolemia from the thiazides if prolonged, and also contraindicated in patients with renal stenosis. And that's the end. Thank you very much for listening.